right, so my name is Dr. Pachter. I'm here to talk to you guys today about substance use disorder. And thank you, Dr. Khan, for inviting me. And a lot of kudos to PM Pediatrics to begin with for wanting to have some more information about substance use disorder. Because if any of you had similar experiences to me, then we actually have zero training in substance use disorder through medical school and residency. I could remember during medical school, I had one lecture from a psychiatrist. And I really don't know why I even remember this blurb. I think it might be the fact that the girl I actually was dating and went to medical school with, actually years before that, was a heroin user. So I think maybe I was paying more attention to this lecture that day, but it just sat with me years after. Remember, the psychiatrist had a slide on the board that said, addiction is a choice, not a disease. Don't let anybody ever tell you anything different, and he moved on. That was the end of our substance use education.
Just want to turn on your mic.
That was the end of our substance use education for literally the entire 4 years of medical school. Then I transitioned to an intern at Plainview Hospital, and I'm sure you can all remember the amazing experience of being an intern with your little white coat and being in the ICU in that somewhat intimidating environment. And we would walk around with the cart with the ICU attending, and he would go from patient to patient. There were like 20-something beds, and there was always one bed in the corner with a patient who was in withdrawal. And he would look at the patient and he would say, you don't need to know anything about that person, and we moved on to the next patient. And that always sat with me because the rest of the patients were intubated, they had lines in them, but there's a awake, usually a young person, acting kind of interestingly, and you never do anything about it. So then you go into practice, and whether you're in urgent care, ER, primary care, a lot of our patients are suffering from alcohol use disorder or substance use disorder, but if we're not learning about it, I mean, how many hours did you spend learning about parasites and infections that we're never going to see? But something that is, day in and day out and literally killing tens of thousands of people a day, it's a field that's just now starting to come along into medical training, but still a long way to go. So I do appreciate you guys, viewing today and coming here today and inviting me to speak to on this topic. I am a board-certified family practitioner and a board-certified addiction specialist. We cannot rely on addiction specialists alone to treat substance use disorder. There are nowhere near enough of them. So it's the people who are on the front lines day in and day out seeing patients that have to be more equipped to recognize when patients have a substance use disorder and to know how to refer them to treatment or to treat them ourselves. I am employed by Stony Brook Community Medicine. I'm the medical director of an outpatient rehab center, and I have no financial disclosures or conflicts. Addiction medicine is, as I alluded to before, recognized by the Board of Preventive Medicine. You can either be a primary care doctor or a psychiatrist to get board certified. A lot of people don't know that it's actually a specialty, but it is. But as I alluded to before, you don't need to be an addictionologist to treat these patients. You're seeing patients with substance use problems, and you may not even be recognizing it. So we all need the background to be able to recognize and handle these patients. Today, I want to educate you guys on how to screen for substance use disorder, how to recognize substance use disorder, understand opiate withdrawal and the treatment of an opiate use disorder, and we'll, at the end, give a brief overview of cannabis in youth and a brief overview of e-cigarettes in youth. Now, there's no way you're going to learn from an hour lecture all of this stuff about substance use disorder. So really, my objective today is if one person in this room or one person somewhere out there in cyberland can take a different approach to this problem, that can literally transform the lives of hundreds of kids that you're going to be seeing over the next few years. So again, if one person takes something out of this presentation today and starts being a little bit more in tune to recognizing when somebody may have a problem and talking about it to that patient or to their parents or to both ideally, or making recommendations to their primary care doctors, then this will definitely have been worth my hour drive out, hour drive back, and hour with you. And a lot of time actually putting it together. It should be no surprise to anybody that kids use substances. Don't pay too much attention to the actual percentages up here, because depending on where you go for your source, whether it's the CDC or the National Association for Drug Addiction, or anywhere on Google, the numbers are going to change. But what I want you to take from this slide is that these are the most common substances that our children are using. And when I say children, I mean kids from the age of 12 years old to 24 years old. Alcohol and tobacco are number 1 and 2. They're neck and neck, followed by marijuana, amphetamines, synthetic marijuana, prescription painkillers. This number is interesting actually here. It says 7.1% of school kids who've used over the past year, but in a few slides later, you'll see the number is a bit lower. You can read the rest off to yourselves. I don't have to list them out for you. Today, we're going to be highlighting mostly cigarettes, e-cigarettes, marijuana, and opiates. And this slide just condenses some of that information a little bit better. Look how many of our adolescent patients are using these substances. Cigarettes, from 8th grade, 2.6%, but up to seniors in high school, 10% of our seniors are smoking cigarettes. That's being exceeded now by e-cigarettes, which is 12.4%. 33% of our kids are drinking. That means if you guys see, 1,000 kids in one of your practices a week, if you're not recognizing 300 kids who are drinking, you're not asking the right questions. Our kids are drinking alcohol at insane levels. Now, alcohol would take 4 hours of discussing on its own, so it would be too much to bring into the lecture today. But the same thing with marijuana. Marijuana is about 22% of our seniors in high school are smoking marijuana. And that does have to be recognized, and we'll talk more about that at the end. Opiates, it's really hard to pinpoint because it relies on a lot of self-reporting, and the data just is really hard to gather on how many of adolescents are using opiates and prescription painkillers. But 47,000 people in 2017 died of an opiate overdose. That number is increasing. Those 47,000 people were mostly adults. In 2015, which is the last year that relevant data is for, about 4,000 kids died of a drug overdose, half of those being from opiates. Now, that may be a very small percentage of the close to 50,000 total overdoses, but all of the rest of those people were adolescents at one point. So the goal is not to recognize when somebody actually has the problem. The goal is to recognize when somebody is at risk of developing a problem and trying to prevent it from becoming an issue. Because I see in my hospital rounds every day when I go detox, I see 10 patients a day, 5 to 10 patients a day. Then in my office, I see plenty of substance use patients. The story is always the same. Now, you see on the news, you read in a story, so-and-so passed away from a heroin overdose, or the number of people who are using prescription painkillers. And yes, these people are middle-aged white men. And it is a lot of middle-aged white men who are coming in for detox initially, in addition to a lot of 20-year-olds and 18-year-olds and 30-year-olds who are using heroin. But the story is always the same. Started smoking cigarettes at 9 and 10 years old, started drinking alcohol at 11 or 12 years old, started using other party drugs when I was 12, 13, 14, 15, got my hands on mom's painkillers when I was 18. Shortly after that, I started using heroin. It is very, very rare that I have an adult patient come to the office or to detox and they just started using those pills right away. So again, if you guys can start asking the questions ahead of time, you can literally prevent that person from going from the story I just relayed to you to what's going to happen to them 20 or 30 years later. If I encounter an adult or somebody after the age of 24 with a substance use disorder, it takes that person on average 8 years to reach complete abstinence. Now, complete abstinence doesn't necessarily have to be somebody's goal. There are a lot of people who are using heroin or using drugs who don't want to stop using. But if you can keep them on medication and keep them in treatment and give them a harm reduction approach at first, you'll retain them in treatment, there'll be less hepatitis C, there'll be less overdoses, there'll be less hospital visits, and eventually that person will want to stop using drugs because it's just completely destroying their life. But it takes 8 years to get to that point. For a kid who's between 12 and 24, it's going to take a much longer time if you don't intervene. On average, 10 years of that person being in treatment if they reach the level of substance use disorder. So again, I can't emphasize enough how important it is to recognize these problems early and at least have a discussion. Because we live in a time where there are not too many respected professions. Politics is out, the law field is out. People actually still respect and listen to their doctor. If you have an adolescent, most of the time, they actually do. If you have a kid coming in, an adolescent, a millennium type, they can be very difficult to deal with, but they actually still respect you. The data does show that people still listen to their doctor, regardless of what age they are. So you're not wasting your time. You may sometimes feel that you are, and you may feel that you're lecturing to somebody who doesn't want to hear it. But if you do that over and over again, even if it's just one time, and then their friends say, oh, I saw Dr. So-and-so, did they ask you about this? That actually can have a really lasting impression. So it can be frustrating, but try not to get too jaded. The other part of it is most of us, I shouldn't say most of us because I didn't gather any statistics, but many of us are working for for-profit organizations. And a lot of our day-to-day work is sort of being dictated by somebody else, and this is not a criticism. We wouldn't be able to pay back our loans otherwise. We wouldn't be able to live on Long Island otherwise. So it is what it is. But because of that, that's not what we went into medicine for. And sometimes you can lose sight of the good work that you really wanted to do. And being able to prevent somebody from dying 10 years from now is actually really good work. So what I really like about treating patients with substance use disorder is you find somebody at literally the worst stage of their life, which you obviously get no joy out of, but to see a patient like in the throes of death, coming out of that and following up in their office, and then having children and bringing them to their office with them, and watching them really transform their lives it really shows you that you can make that big of a difference in somebody's life still, regardless of the type of problem they have. And people always used to ask me all the time, how do you deal with those patients? How do you deal with those people? To me, it's way more gratifying, with no disrespect to my patients with other ailments. Many adult patients don't change their behaviors. You're treating diabetes, the A1C is going up, you're treating high blood pressure, here's a second medication, here's a third medication, you're still smoking. And at the end of the day, when a person comes in and their A1C goes down and you didn't have to put them on medicine, you like celebrate with them. It's, I cannot believe you actually did this, because very few people do. So if you can have this type of impact on more people starting at an early age with a substance use disorder, it actually is very gratifying, despite the negative stigma and the social implications that come along with substance use. Now, anybody who uses a substance does not have a problem. Well, you're allowed to experiment. There are probably some of us in this room, or some of us out there in cyberland who have done dumb things while under the influence of a substance. That doesn't mean that you have a problem unless it's a repetitive behavior. So in order to qualify for a substance use disorder, you have to meet some of this criteria. Hazardous use. Did you ever drive a vehicle while you were drinking? Social or interpersonal problems. Are you getting into fights with people because of your drug or alcohol use? Are you not going to work because you're using it? Are you skipping school days because of using substances? Are you experiencing a withdrawal or a tolerance to the substance that you're using? Are you starting to use larger amounts over longer periods of time? Have people made repeated attempts to quit or to cut down their use and been unable to do that? Spending more time using? Are there physical or psychological problems related to the use? Stopping playing sports or stopping other activities that you enjoy because of it, and really craving to use the substance. Now, if you have one of these, you may be at higher risk of developing a problem later on. 2 to 3, it's a mild substance use disorder. 4 to 5, moderate. And 6+, you have a severe substance use disorder, which is the majority of patients that will come to my presentation by the time we unfortunately have to meet in a detox or an outpatient setting. You'll hopefully be able to come across a patient more in the early stages, and again, literally be able to help prevent it progressing from one stage to the next, because an adolescent or a child who starts using early has a much higher risk of developing a substance use disorder later on in life. Contrary to my esteemed psychiatrist at the University of New England, substance use disorder is a disease. Now, I gave a lecture recently to some of the residents at Stony Brook Hospital, and one of the interns took exception with my word disease because it's a substance use disorder. And yes, there's a technicality. If you have a problem with me saying it's a disease, I'm sorry, it's a disease, even though it's labeled as a substance use disorder. This is a medical problem that people are dying from, for which there is medical treatment. So rather than getting caught up in semantics and the DSM-5 and criteria, let's just agree that this is a problem that we can help solve and treat successfully. I don't know how much you guys really will go into family history in an urgent care setting, but it is important to know that 50% of substance use disorder actually is hereditary. Now, that doesn't mean that if your mom or dad has a drug or alcohol problem that you have a 50% chance of becoming substance use disorder yourself, but there actually is a 50% hereditary component to it. So if mom was a heavy drinker or if dad was a cocaine user and you started smoking marijuana at the age of 12 years old and you came to urgent care and you were 15 years old and you had a shoulder injury and got a Percocet prescription, that's really going to increase your risk of developing a problem later on. So family history may be something you more want to delve into, but prescribing Percocet may be something you just don't want to do, period, which I'm sure, especially in today's, environment, it's something that you're not doing very frequently. And I see a lot of head shaking, yes, so I think maybe I'm onto something there.
Quick thing, have they started to identify the genetic role, specific genes that set you up for this? Or something?
There is some PET MRIs that they're doing to try to highlight areas of the brain and that has been very well studied as far as the reward pathways and your amygdala and the locus coeruleus leading to withdrawal symptoms. They're still trying to pinpoint actual genes, and there's not still a whole ton of money being supplied towards substance use research. There is more coming. They're doing some at Columbia, and Northwell is opening a center in Calverton where they're supposedly doing a lot more research. So we may be onto that. But from the data and from a historical perspective, now I never did an actual study myself, but in the same light of patients who come in and they gave me that story where at 10 they start smoking, 12 they blah, blah, blah. Very, very few do not have a family history of substance use disorder. The story really is extremely predictable. And again, as I alluded to before, early use will increase the risk of developing a substance use disorder. And by the way, for anybody who's, I'd see that white box by you. If anybody has questions while I'm going, you can feel free to just interrupt me, okay? So just grab a supporter real quick. So I think the one area where you guys can really play a huge role is in screening for substance use disorders. Has anybody in this room screened anybody for substance use disorders in the past week? Has anybody in this room screened for substance use disorders? People in Cyberland need to know there are 4,000 people in this room and nobody raised their head. Has anybody in this room screened for substance disorder in the past year?
So maybe vaping in terms of...
For vaping, okay. Now, have any of you used any standardized tools for screening? Okay, I hate standardized tools. But these standardized tools and surveys for substance use disorder have really been proven to cut down people's risk of developing a substance use disorder. And they are not time consuming. And you don't have to sit down and say, hey, Johnny, I'm going to ask you some questions about drugs and alcohol right now. You have to find a way to squeeze it into your regular urgent care type visit, which I think can very easily be done.
Where would you recommend finding some of these screening tools? Perfect.
Right here.
Thank you.
Thank you for...
I feel like I would use it more if I knew how to access them. Or
Make sure I give you those $5 for planting that question. So these are a few websites you can go to for excellent screening tools, and I'm going to go over one in detail with you on the next slide, okay? But there's a whole bunch of them. Again, they're not very time consuming, and I'll show you how you can use one and go through it right now, actually. This is the one that I personally like the most because it's the least time consuming, and you can have a conversation with this one. So let's say you have a 15, 16-year-old male or female coming in for an earache, right? While you're looking in that person's ear, your ear looks infected. Smokers have a much higher risk of getting ear infections. Have you ever smoked? Now, if that person says yes, then obviously you'll start asking more questions. If the person says yes or no, while we're talking about cigarettes, you probably see on the news, you probably hear it, a lot of people are using drugs now and again. Have you ever drank alcohol or used drugs? So your regular visit can transition very easily into these types of questions. And I think if Johnny, who is still our patient, is sitting there with their mom or dad's going to be like, wow, that's really great that they're asking these questions. And if you ask it in such a way you're not going to give a sneaky 15-year-old Johnny a chance to lie. You're going to catch him off guard, and they're most likely going to be honest with you. It really has been felt that these questionnaires lead to an open dialogue and a good conversation. Another transition, I'm sure you get plenty of people coming in with headaches or some sort of muscle ache, right? Injuries in an urgent care setting. I know your shoulder really hurts. You've probably seen in the media or learned in school that a lot of people are using drugs. Have you taken any Percocet or any pills for this on your own? And that could really lead to opening up the door to these questions. So you don't want to just come out and ask these questions. You want to transition with, have you ever used drugs or alcohol in the first place? And if that screens yes, then you move on to the screening interview, which is these questions. It's crafted as the acronym, which we'll go through. So if somebody admits to using substances, have you ever driven in the car with someone, including yourself, who's been under the influence of drugs or alcohol? Did you ever use drugs or alcohol to relax or feel better about yourself to fit in? Do you ever use drugs or alcohol while alone? Did you ever forget things that you did while you're using alcohol or drugs? Did family or friends ever tell you to cut down? Or have you ever gotten into trouble while you're using? 2 or more of these questions positive is a positive screen. So great, you got a positive, now what? Okay, great, have a great day, here's your amoxicillin, hope your ear feels better. If you're going to screen, you have to have a plan. So first thing you need to know is the resources in your vicinity where you can send these patients for further help. If somebody screens positive for 2, in our area alone, there's not that many centers that treat adolescents. There's South Oaks, which is in Amityville, and there's Bellport Outreach. I think it's Bellport Outreach, but one of the outreach programs has a specific program for adolescents. Otherwise, you should have a list of just one-on-one private counselors that people can see, a list of addiction specialists. Now, a lot of addiction specialists are psychiatrists or internists who can't see pediatrics. There are not that many family practitioners who are addiction specialists. I'd be happy to see any of your patients. I'm all the way in Southold, but I have patients who travel from even further, and I'd be happy to give you my information at the end. One of the better ways that you can deal with this, I shouldn't say better, one of the other ways that you can deal with this is making some sort of a plan with the person. So let's say, Johnny does admit that he's been smoking cigarettes and he's been smoking marijuana and he's doing it 3 or 4 times a week. You have a conversation about it with or without the parent. You do not need a parent in the room with a person who is using substances. And sometimes that's more beneficial because you can have an open dialogue. And you can either make a plan to follow up with that patient yourselves, which I realize in an urgent care setting is unlikely, but have that person agree that you can contact their primary care doctor. I'm sure anytime somebody comes in, they get a note that you saw the patient, right? So you can have this craft survey printed out, sent to their primary care doctor, with the flag. We surveyed your patient, they seem to have a problem, please follow up with them and discuss it more. And again, that can lead to a more valuable experience for the patient.
Do you have any recommendations for how to approach, having the conversation with,
I don't want to hit your water.
So I find it difficult, and especially in the certain populations where we work, there's the parents there can be, I guess for a lack of better words, like helicopter parents or whatever. So how do you approach the awkwardness of asking a parent to step out of the room? I feel like I struggle with that because there's definitely parents. I feel like I kind of disagree when you say that the kid is most likely going to be honest with you. I don't necessarily agree with that. I feel like a teenager, if their parent's sitting in the room, even if you're catching them off guard, their first instinct is probably to lie about it. So how do you then have that conversation where you ask mom or dad to step out of the room? To me, I find that awkward, and I don't know how to navigate that situation.
It's an excellent question, and we can disagree, I guess, about that all day. I think it's going to actually come down to your approach. A lot of that, I think, is going to be a confidence in what you're doing type of approach, right? So if you just flat out say to mom or dad, listen, I have some concerns about, I guess we'll stick with Johnny. You mind if I just ask him a few things on our own, and I'll be happy to get you right after we're done. And if a parent says no, they say no. I mean, you have limited time with the person. You're trying to do your best job. If you lead with I am concerned, then my feeling is that would lead to a much more openness and less of a defensive stature. Anytime you as the provider are expressing a genuine care for their child who they brought to you, and if they're defensive and if they don't want to go into it, then okay, at least you gave it a try. But I think practice and doing it more frequently will lead to that. I mean, I'm family medicine, so I see kids all the time. I have yet to come across a parent. Okay, back up. Different story. I know these people. I see them time in and time out, and I may have the parents as patients also. So unfair sort of comparison. Yeah. But when there are concerns, it's never like, there's never a face, there's never a grimace. It's, oh, absolutely, I'd be happy to wait outside. So I think the more that you do it and the more confident you are in your approach, the more likely you'll be able to. And going into the person being honest with you, tell them this is confidential. I'm not getting your mom. I'll get your mom after we're done, but I will not tell her anything about our conversation if you don't want me to. If there's a concerns, I would like to, but if you don't want me to, I don't have to. So if you can make them feel that you're generally interested in their well-being, a lot of people will let their guard down. Or you can just smack them. That might be good too.
I mean, do you do it for UTIs and sexual history, right?
Yeah.
I guess one other question, is there ever a setting where you would ask in front of the parent? Like, is that advantageous in some
Sorry.
cases?
I think that has everything to do with how comfortable you are. I think it would be perfectly, now you're not going to start looking in the person's ear, if we use the same analogy, as, oh, I see something, I need your mom to leave. Right? So you can start with the initial questions in front of mom, right? So you're looking in the ear, a lot of people who smoke have a higher risk of ear infections, or, listening to the lungs have upper respiratory tract infections. Have you ever smoked or used an e-cigarette? If you sense something, if you don't believe that they're telling you the truth, you can then say, you know what, Mom, do you mind stepping out of the room so we can talk privately, one-on-one? So you can transition that way. But it would be very awkward to just say, get out of the room, I need to ask him some questions. Then they'll be like, well, what the heck are you asking my kid, right?
So you're recommending starting maybe with an initial question or two, and then if you find that it's getting...
Absolutely. And that the parent and the patient are open to it, then I think a private 2-3 minute conversation. This is not, you probably got a bunch of people waiting. So this is not going to be a 20-minute thing. There's just going to be, I just have a few quick questions. I just want to talk to so-and-so for a few minutes. You mind stepping out? I think that would go perfectly fine.
Long distance.
Thank you. So I just wanted to throw in my 2 cents on this. What I find kind of works is to make it very neutral in the sense of like, okay, when I'm done with the history, I say, I'd like to talk to all my teenagers alone. So I'm just going to ask you to step out for a moment. So it's like, it's not any judgment. It doesn't seem like, I actually think, sometimes, better to not show any concern, because then it's kind of like, then the parent's like, what happened? So it's, just make it a very neutral. This is what I do with every teenager. And then you can ask your sexual history also. You can ask your substance abuse issues and just kind of feel it out. And I also always, as you said, like reassure the patient, like this is confidential. I had moms come out of the room because I want to, this is confidential. I'm not going to go back and tell them anything. The only way I'm required to tell them is if I'm concerned that you're going to hurt yourself or hurt anybody else. And usually that's like a good segue, and it goes pretty easily from there. So that's kind of like how I approach them.
I think that's excellent. I think that's great advice and a great approach. I agree. If you make it a standard part, then nobody feels like you're isolating them or taking them out. That's great. Any other questions? So now we'll go more into specifics about specific substances. Now, opioids is a general term for opiates and opioids. Opiates are natural products, morphine, codeine, anything found in the environment. Opioids are synthetics, so oxycodone, heroin are synthetics, but they get lumped together under the one term opioids, which, you notice I haven't used the word addiction. When you're isolating substances, it's an opioid use disorder. The vernacular is no longer drug addict because of the social stigma. Part of the problem treating this disease is, again, it not being recognized as a legitimate medical disease and people thinking that it's a moral failing. And so you try not to use terms in patients, urine tests like dirty or clean or addict or anything that would have a negative social stigma. So the DSM-5 categorizes a substance use disorder, and then you're more specific in the substance of choice: opiate use disorder, alcohol use disorder, benzodiazepine use disorder. I don't have to name every substance. You get the point. And nobody's going to come, well, I shouldn't say nobody, but few people are going to come to an urgent care setting, with a sign or waving their arms, hey, I'm using heroin, can you please help me? They may, if you open yourselves up to being able to treat that problem, but again, I don't know how much you can do in an urgent care setting regarding that. People come to me all the time with that, but that's a different type of environment. So in order for you folks to recognize an opiate use disorder, you have to go back to medical school and relearn your signs of withdrawal. You may be seeing patients in withdrawal and not recognizing it right now. So opiate withdrawal, early opiate withdrawal, several hours after the last dose of either a pain medication or heroin, will be yawning, some sweating, a little bit of anxiety, dilated pupils, piloerection, which is goosebumps and your hair standing on end. Then as the hours progress, maybe a day, 2 days later, depending on the half-life of the substance used, there'll be more abdominal cramping and just complete discomfort, more agitation, muscle aches. So if patients are coming in with abdominal pain, vomiting, that's also another transition to ask, I realize this is unlikely, I just want to make sure I'm using any illicit substances. And you may surprise yourself that, more people are telling you, yes, actually, I ran out of pills, last night and I didn't know what else to do, so I came here. Maybe with a complaint, trying to be a little stone-faced, maybe coming in complaining of some sort of a pain, hoping that they would just get a prescription, tide them over till they can, meet with the next person that they would typically get them from. So the point is, if you're not thinking about it, you're not going to be able to recognize it or treat it. Is it going to be day in and day out? No, but it's probably being missed now. Look how many people are using substances. So it's like any disease. If it's not on your head, you're just going to pass right by it and miss an opportunity. The obvious ones would be if somebody has track marks in their arms, if they have a heart murmur and a fever. Now, clearly, you have to think of infectious endocarditis from drug use. Track marks is just a line of needle marks along a vein. It's not an infection. It's really just a sign that that person is continuously using IV drugs. You just have to find the new place along that vein to insert the needle. I know a lot of people don't like to look at this slide, so I'll get off of it for you. Oops. More likely, patients are going to come in with vague complaints. If somebody's using substances, they might be more tired lately. They may be withdrawing from school activities. Mom may say, he used to be doing so well in school. He's not doing so good anymore. Now he's complaining of these stomach aches all the time. We don't know what's going on. They might be real moody. They might have new psychiatric issues. So again, if somebody has a vague presentation that can be somewhat psychiatric in nature, you absolutely have to screen for substance use disorder. And again, you're not necessarily going to be able to completely treat it, but you want to get that opportunity to recognize that this is really what's happening with this patient to get them to where they need to be to actually be treated. Somebody mentioned something before about urine toxicology. The American Academy of Pediatrics and the American Society for Addiction recommend against screening when mom or dad say to screen. If you're going to test, if you don't know what you're really doing with those tests, remember, it's a test. So if you do a rapid strep, what is it, 90% sensitive, something like that, right? But most of the time you send it out for a culture to verify, right, if it's a negative. So if you have a negative test, you're not going to tell mom or dad so-and-so, if they have a fever and a sore throat, you may not prescribe antibiotics right away, but you're going to send it out for a culture. You're going to say, the test came back negative, but that doesn't mean they don't have strep. If so-and-so comes back negative for an opiate, it only stays in your body for 2 days. So if it comes back negative, you're not verifying that that person is not using drugs. On the same token, if it comes back positive, that doesn't mean that that person is using drugs. It is really true that if somebody eats poppy seeds, it can come back positive for opiates. Now, not if you have like a half of a bagel, but if you had two sesame bagels, if you had like a sesame muffin, it really can come up positive for opiates. If somebody's coming in with a headache or a runny nose and they took Benadryl, it could come up positive for amphetamines. If somebody's on some sort of antidepressant, it could come up positive for a multitude of substances. So if you're going to do a test, you have to be prepared on how to handle those results. Well, I hate picking on Johnny, but Johnny, we did a Utox, and wow, it's lighting up like a Christmas tree. We better get him to the closest hospital. He might not be using anything. So I would recommend against just screening just because mom or dad asks you to do it. Additionally, there is no recommendation for parents to do home screening. It's never been studied. The tests are probably just as good as the dips that we can do in an office, but there has never been a study showing, or I don't even know if a study's ever been done, but there is no data to suggest that parents doing a home test would be helpful in decreasing the risk of so-and-so developing a substance use disorder. So again, with difficult parents, I would just say, I can't stop you from doing that, but I do not recommend it. There is no guidance from medical societies to say that it's helpful. And I'm sure parents are asking you once in a while about drug tests, right?
Yeah, we had that exact situation happen where a parent kind of pulled one of our clinicians aside and asked to do it involuntarily.
And what did they do?
Oh, we did not do it.
Did not do it. Oh, good, good for you.
It's happened multiple times.
Multiple times, parents will bring their kids in for testing, and I have never done it.
So in those types of scenarios, that would be another great way of saying, look, parents come in all the time for this. Maybe they don't, maybe it's infrequent, but say the same thing as you alluded to before. Parents come in all the time, and our approach to this is let's just have a conversation with your son or your daughter by ourselves, and then you could feel the person out and maybe get into more details about it. A conversation is way more helpful than a test. All tests have to be taken with a grain of salt, whether it's a UTOX, a rapid strep, an MRI, a CAT scan. They're just tests. They're going to be dependent on the person who's reading them and what's going on at that specific time. There could be false positives and negatives, and it's not the end-all be-all of treating, right?
If we take that scenario a little bit further, so if a parent comes in saying they want the kid tested and they're being open about it, and we say we prefer not to do it in this setting, we prefer to have a conversation, should that conversation then be with everybody, or should we pull the patient aside first and then try to, regroup?
If everybody's open to it being done, including the patient,
Yeah.
then you can do it.
Okay.
If that's the reason that they're there, right? If the person is really looking for help and saying, yes, I'm using such and such, it's important to have a UTOX on record to verify a diagnosis, just like the rapid strep, right? You can't prescribe amoxicillin for a kid if it's not strep. I mean, you can, but it's really not appropriate, right? So you need to have some sort of a documentation that this person has strep, we gave amoxicillin. In order to substantiate a diagnosis, you just want a test to verify that. With that said, if the person didn't use within X amount of time, you may not get the result you're looking for. In an urgent care setting, again, what are you now going to do with those results? So that's the other thing. If the person is willing to give it for documentation purposes, great. But if you go through some sort of a screening mechanism and you gather all this info, it will be much more beneficial to say, look, thank you so much for being open. I'm so concerned about you. Here's a place where you can go if you want to get help right away. And tomorrow I'm going to call Dr. So-and-so, your primary care doctor, just to let them know about the conversation so they can follow up with you next week. And that would be way more helpful than just making somebody pee in a cup, right?
Is our, I don't know if, is there, this isn't like a question for everybody. It's more just for specific to PN pediatrics. Is our, when we collect a urine for a UTOX, is it like something that's done rapid or is it send out? I don't know how that works. Oh, it is a send out. Okay. So there's no. So I know you briefly mentioned like a dip or something.
So you probably have CLIA waivers because you do lab tests in your offices, right? Like urine tests. So there are urine toxicology cups that I find much more beneficial because it's point of care testing, and it will give you the results right away.
We don't have that. Oh, okay.
Now those are much less sensitive, and you'll get more false positives on those. But for a face-to-face encounter, what are you going to do with it if it comes back 3 days later, right? It's a missed opportunity. It's still beneficial if you're going to be sending them for further help, but to have the conversation right then and there about it, it's a lot more productive with the dip. In dealing with opiate use disorder, it's important to treat for withdrawal. Sending for counseling, especially in an adolescent or a teen, counseling is very, very important. I am not minimizing the role, but being on some sort of a medication to help that person is really the mainstay of treatment. Now, the problem with our medications, whether it's methadone or a medication called Suboxone, is that it's never been studied in kids. So I can't sit here and tell you guys to start prescribing Suboxone to your children, pediatric patients. I would. If I had a pediatric patient coming to my office that's using heroin, there would nothing in the world would stop me from them prescribing the medication. But for 18 or older, it is studied and has been verified to work. And it's really an interesting medication. Now, have any of you come across people on Suboxone?
You need a certification to.
Yes,
yeah.
which we'll get to. None of you have, I mean, you've seen.
I actually did when I was in school. I had a lot of exposure to pregnant women who were on, and I did a lot of research on whether or not Suboxone or methadone was either or more effective than the other. But I don't have any experience with using kids only in pregnant women.
So pregnant women are in the category of people who I would chain to a door and make them go on medication until, because you're dealing with two people's lives now. I would not literally do that for anybody who is going to take this out of context. But buprenorphine alone without the naloxone, which is a medication called Subutex, or methadone are equally effective in treating pregnant women for their opiate use disorder. But have any of you, granted there are a limited number of people here in the room, have any of you come across a newspaper article of a patient you have seen in urgent care being arrested or having a drug problem? Never? Okay, well, I'm sure some of you have read articles about patients who have drug problems who did such and such, and they always, if the person is on medication, and they found the dirty medication Suboxone on their possession. Like, these articles make like this medication is something that increased their bad behavior for what got them arrested that day or made them high. So I just thought it was important for, if you do come across people on this medication, to understand how it works. So heroin or strong opiates are full agonists to the opiate receptors, right? So that means that the heroin is binding to those mostly mu opioid receptors in the person's brain, right? And the rest of their body, spinal cord, blah, blah, blah. What buprenorphine does, which is one of the generic ingredients in Suboxone, is it's a partial agonist. And it will attach to those same receptors with a higher affinity, but it won't saturate them, so you don't get any sort of negative effect from it. It only saturates them so much. So you can't get high from it. You can't go into respiratory suppression from it. You can't overdose from it. And only so much of the medication will actually work. There's only so much that somebody can take. Now, people do overuse their medication, but that's sort of a psychological effect. There's a cap as to how much it will work. Additionally, there's another ingredient in Suboxone called naloxone, which is basically Narcan. Suboxone has to be taken under the tongue. It has to be dissolved under the tongue, go into your system, go through first pass through the liver. The naloxone is not an active ingredient. If the person tries to melt down the films and tries to inject them, or it comes in the pill phablet and you try to sniff them, if you try to avoid first pass to the liver, then the naloxone kicks in and prevents the medication from getting you intoxicated or overdosing from it. So it's actually really a neat medication. And a lot of stuff that we prescribe, we don't really understand the pharmacology for, but again, there is, with the thanks to a lot of 12-step groups and negative portrayals in the media, there is a negative stigma at times of patients being on medication to treat this disease that they're going to die from. And again, that's really just because of misinformation and a lack of knowledge on the outside. So medication-assisted treatment, which I actually hate that term, the medication is really the mainstay of treatment for patients with substance use disorder. You'll retain them in treatment for longer, you'll decrease their risk of contracting hepatitis C, you'll decrease their risk of overdosing, you'll increase their ability to have a better social life and a work life. So that really should be what people are doing. Counseling by itself is rarely effective. It's not something that you can talk yourself out of as much as people try. Methadone is another option, and there's another medication called Vivitrol, which is also an excellent option for patients with opiate use disorder. You asked before about getting wavered. This is like the dumbest thing in the world, I think. Doctors don't need a waiver to prescribe opiates, and you can prescribe as many of them as you want if you so choose, right? But the DEA or whoever, I'm sure the intentions behind this were good. Well, I shouldn't be so sure of that. But they put this restriction, and it's great that you have to get education, you have to take a course, but then once you get wavered to prescribe Suboxone, you're only allowed to prescribe it to like 70 people or 30 people for the first several months. It's nonsense. It's arbitrary. but it's better than not having a treatment available at all. So if one person in your urgent care setting got wavered and you were able to prescribe the medication for patients in withdrawal, that would be an excellent bridge to getting them to further treatment, which is what's being done in the emergency rooms now. There's a big initiative for patients to be able to come to the emergency room, recognize that they're in some sort of opiate withdrawal, get prescribed their first 2 to 5 days of Suboxone treatment, and make an immediate referral for treatment elsewhere so they can continue with the medication. So if anybody was interested, I would fully support you being wavered to at least have it as another tool in your belt.
It's crazy. You would think we would need the 8-hour course to prescribe the opiates.
Right, exactly.
1-hour course to undo.
Do you guys have to take the safe opiate prescribing course?
So we actually decided, I think for multiple reasons, to not get a license to prescribe opiates for any of our offices.
Oh, so you don't even prescribe it.
So we don't even prescribe it. And it actually makes it much easier. It takes it out of the discussion.
Yeah, absolutely.
We say, look, Motrin has been shown to be equivalent in a lot of studies to, oral opiates, and we feel, as a practice that it's the safest way. The other thing, it was prohibitively expensive, actually, to get that license for all of our offices. So it was both a moral and financial decision, but it made our job easier.
Yeah, I suppose if a person, just had a limb removed and really needs them, you're not the place that they should be going to in the first place, right?
Exactly, exactly.
Yeah,
So,
that's great.
and we've been practicing that way for years, and it's pretty sustainable. We are able to offer intranasal fentanyl and intranasal midazolam for procedural, either severe pain in the office or anxiolysis, but that's it.
So if you were prescribing opiates, so any practitioner who prescribes opiates has to take, I think it's every 2 years, you have to take a safe opiate prescribing course. This consists of going onto a website, logging in, paying a fee, and printing out a certificate. But each state that does this can say, well, our providers are trained. And there are hundreds of them online. Some of them are more extensive, but of course, you find the person, somebody finds the one that's the least time consuming and passes it out to everybody else. We're busy. It's difficult to sit down in front of a computer for 4 hours to take a course. So again, the intentions are good, but the rollout is not the best. Another way to opiate overdoses on Long Island for the first time this year have actually started to decrease, and one of the reasons is because of more widespread distribution of Narcan. So you can absolutely have Narcan in your offices and just offer them to anybody who wants them. The places, did I have that on here? Oh yeah, the places, the Long Island Center for Recovery and CASJ, they'll bring them to you for free. So on patients' way out, look, we just offer this to everybody. It doesn't have to be, you don't have to screen, you don't have to ask. We offer everybody a Narcan rescue kit. Would you like to have one? And patient basically just puts their initials, you don't have to gather their name or anything. They put their initials on a form and they can take one, which would actually, parents.
So he's talking a little bit differently. So we have Narcan available for, acute resuscitation if somebody's in respiratory failure, respiratory distress, but he's talking about kits that you would give to the patients.
Right.
Yeah.
So, mom or dad, you may have a house party one day, the graduation, kids are doing crazy things now. It'd probably be just a good idea for you to have one of these at home, So if it was something, these places are easily accessible and give out as many as you want for free.
How much are they at the pharmacy though? Because I know you can buy it at Walgreens or CVS or.
I have thousands of them in my office. I've never had to look. I really have no idea.
Just curious.
Yeah, absolutely. Anybody have any questions about opiates? So again, as I alluded to in the learning objectives, I'm going to, cannabis and e-cigarettes, just for the sake of time and there's only so much you can absorb in a lecture, we'll sort of be a little bit brief with. But cannabis is becoming more of a problem despite the presentation of it in our media about, being accessible in certain states much more easily or having medical properties. And I think a lot of people are misinformed that don't really understand that there is a real negative of cannabis use, especially in young people. So if I look at this picture, number one, it makes me feel old because I'm like, well, it's good for them. fine. They're at home, they look like responsible people. Now, let's just backtrack for a second. You cannot make a judgment on somebody based on what they look like. Now, many patients who are using opiates in my practice, you would never in the world guess it. So I'm just saying this from a very superficial standpoint. When I look at this picture, it's like, good for them. You know, they're together, they're inside, they're not outside, there's no kids around. Have a good time. When I look at this picture, it gives me the creeps. Like, these are like little young baby kids. I mean, I have an 8 and a 5-year-old. Before you know it, they're going to be, you know, in high school with kids like this. And these may be great kids. Just because they smoke pot doesn't mean that they're bad kids. That's not what I'm saying at all. But it just gives me a visceral reaction. Something just does not feel right about this. Like, these kids should be, you know, playing sports or doing stuff, or like something other than this on their free time in such a big group. But if we go back to that first slide, remember 22.5% of seniors are smoking pot on a regular basis. So this is not like these are the outcasts of their school. Most of us look like we're around the same age. I ran into somebody I went to high school with before, and it was so easy. It was like, just say no. And we remember that, right? You remember that campaign. These campaigns actually carry some weight behind them. So whether you screen a kid for substance use or not, if you're encountering somebody, giving them a quickie on, you know, just say no to drugs. You're 15 years old. Your brain is not developed yet. It's going to take another 10 years. If you start messing around with substances, it's not going to lead you to a good place. And I think part of the problem with this, again, appeal to marijuana is a misunderstanding of how potent it is now. The average House member is 57.8 years. That's the House of Congress. And an average age of a senator is almost 62 years old. If these guys or women have any experience with smoking pot, I mean, that was in the 60s or 70s, where you can probably smoke pot all day and basically just feel a little relaxed and hang out. But since the 1990s, the potency of marijuana has gotten so much stronger. So prior to 1990, it was 2% THC, which is the active ingredient in marijuana. In the 1990s, 4%. Now it's almost 30% THC. And not only are people smoking it, but they're buying gummies or, you know, having some sort of baked good. And the way that your body breaks that down, it can actually literally act like a hallucinogen. So the people who are supporting legalization, you know, for people who are 21 or in some places I think even 18, it's not being very well thought out or regulated, in my opinion. So just because it's being endorsed doesn't mean that you shouldn't take the just say no approach to the patients that you're coming across. And any possible benefits, whether it's preventing seizures or pain or anxiety or appetite or treating substance use disorder, these things have really not been studied. On the study for seizures, so there are a certain population of kids who have refractory seizures that are not responding to traditional medications. Cannabis looks very promising, but the largest study was on less than 20 people. It's not like it's been tested on hundreds, you know, or thousands of people, which has to happen with the rest of the medications that we prescribe. So any list of benefits is really being, I think, a little misplaced. In addition to that, there are no negatives. In the short term, it can affect your attention, it can cause drowsiness, it can cause anxiety, it can lead to mental health problems. If you're smoking a lot of marijuana, it can lead to lung problems and frequent upper respiratory tract infections. There's a possible loss of IQ points in our youth if they're using repetitively. And there actually can be a withdrawal. You can become, you know, a withdrawal from a drug or a medication is always the opposite of the effects that it can have, right? So if people smoke pot, sometimes it calms them down, sometimes it increases their appetite. If you stop using, then it can actually make you more anxious. You can actually lose your appetite completely, start losing weight. So there actually is a withdrawal associated with it too. E-cigarettes, I'm sure you folks see in the news plenty of stuff about e-cigarettes now. There was a kid in, I think it was Ohio, I'm not 100% sure. He just had a double lung transplant. So you have to be screening for e-cigarette use. Again, anytime somebody's coming in with a cough, are you smoking cigarettes or using e-cigarettes? There is nothing good about e-cigarettes. More kids are actually using e-cigarettes now than adults. And it's felt that, first of all, does anybody know who's the biggest producer of e-cigarettes? Tobacco, yeah. So, I mean, what amazing things have they done for us? It's insane. So it's shown that kids who are starting with e-cigarettes will most likely just turn into smokers later on in life. And these things, you know, they've taken away the flavors off the market, but they're really geared towards youth because of that, because it's tobacco. They can transition from one product to the next. E-cigarettes are unsafe for anybody. It's felt that the lung damage that is being done that you're seeing in the news with this terrible pneumonia is actually more related to people who are putting THC products inside of the vaporizer, not so much the flavors, because apparently when they mix inside the THC, there's some sort of a vitamin E that can be affecting the lungs. So this is all being theorized, but completely dissuade anybody from using an e-cigarette. For my adult population, if they're smoking cigarettes, if they now started using an e-cigarette to transition off of cigarettes, I warn them of the dangers, but it may have a beneficial role in that setting. For the population that you're seeing, there is zero benefit. I just never say, yeah, it should be okay. It's not okay, period. Nicotine itself can have a negative effect on attention and can lead to, again, I alluded to before, all the people I see with substance problems started smoking first. You know, marijuana was always said to be the gateway drug. No way, nicotine is the gateway drug. Every person I see with a substance use disorder first started smoking at a very, very young age. So the more you can tell people smoking is bad for you, again, it gets repetitive, but you're not wasting your time. The e-cigarette associated lipoid pneumonia. Anytime you see a patient in your urgent care setting, you know, peds to 24, you say, 26. So anybody in that category who is coming in with an upper respiratory tract, if they're hypoxic, you have to ask them about e-cigarettes because it's not uncommon now. It's happening frequently. This is updated every Thursday by the CDC. This was 2 weeks ago. There were 37 deaths and almost 2,000 cases already. So I had one patient who definitely had this that I know of. And this is what it looks like on a CAT scan, which you probably won't be seeing, but it's a horrible, horrible pneumonia. And it's only treated with supportive care. It's not a bacterial infection. Antibiotics are not going to get it better. So it's really just support and time, and maybe steroids that can help these people. But again, one person just needed a double lung transplant. Again, back to a simpler time when we can highlight what drugs do. But does anybody have any further questions?
I'm curious, what are you going to tell your kids about?
You know,
given everything that you know, I guess.
My kids, again, they're 5 and 7.
If you don't mind me asking.
No, I'm more than happy to talk about my kids in any regard. We actually start talking about it now because my kids love asking me, oh, who did you see? How many boys did you see today? How many girls did you see today? And that's how it always starts. What did they come in for? Well, you know, so-and-so is drinking a lot of alcohol, so-and-so is using a lot of drugs. So we have these conversations now. I think our generation, again, I'm sure PM Pediatrics spans a lot of generations of providers, but limiting to the people in this room, I think we are more aware of this than our parents probably were. And I realized our parents never thought that we would, you know, do things behind their backs either. But I hope that we've learned from our own experiences growing up and things that we've done and seeing our patients and seeing the stuff in the news. So I personally think that the earlier you can talk to people about this, the better. So if you have a 9 or a 10 or an 11-year-old, it's okay to talk to them about cigarettes. Now, you're not going to go into, necessarily going to go into the alcohol unless they smell like alcohol, but you could say, hey, listen, you seem like a really great kid. In order to stay in shape, you know, just don't smoke cigarettes or use any drugs. It's really, really bad for you. Just a quick one-liner, no matter how old they are, can carry a lot of weight. Nothing else? Well, thank you so much for having me.
That was really great.
All right, no problem.